Well, good evening, everybody. We have a lot of people online tonight, and we have several people here in the venue. First of all, I want to thank Nick Ratcliffe of TRB Chemedica, and they make hyaluronate lubricant drops. He's very kindly sponsored this evening. This is Nick. He works for this Swiss firm called TRB Chemedica. Thank you very much.
Thank you.
And we want to introduce here, we have Lisa Jagan. She is our guest speaker tonight. She's also a Clinica London Oculoplastic Surgeon, recently joined us from Toronto. You'll tell us a little bit about yourself at the beginning, won't you?
Sure, of course.
Fantastic. And she's going to talk about ptosis. And one of the things I heard people saying in the sort of, we've just been eating and drinking here for a few minutes before, I hope you are as well at home. And they were saying, ptosis, we see that and we never know what to do. And we're scared of it because it could be anything. So I think we're going to learn a lot tonight from you, Lisa. So big welcome.
Thank you.
Welcome people online. Welcome people here. We'll step to the side.
Thank you, Jane, and thank you for everyone who's joined in person and online. So I'm Lisa Jagan, and I trained in Canada. I did all of my ophthalmology training and my fellowship in oculoplastic and reconstructive surgery in Canada, but I've moved to London and I've been living here, and I'm working only at Clinica London, which is where I'm building my practice. So I want to get right into our talk, which is about the life-threatening causes of ptosis. I have no financial disclosures that are relevant to this talk, but we already have thanked Nick for his support through TRB Chemedica. Apart from identifying the life-threatening causes of ptosis, our aim tonight is for you to walk away with a standardized approach that will allow you to see a ptosis case and know how you're going to handle it in order to make sure that you're ruling out some of these life-threatening causes of ptosis. We'll also, near the end of the talk, switch to a part where we're looking at distinguishing between ptosis and pseudotosis, and we'll also consider some of the interplay between the ocular surface and patients who have ptosis. Let's jump right into a case because I like cases. This is a patient of mine who initially presented to their optometrist, and she's a 33-year-old woman. She's bothered by her droopy left eyelid. And her reason for coming into the optometrist was that she did not like how her eyelid looked aesthetically. So she wanted to be referred to an oculoplastics person in order to consider surgery. As the optometrist, you do your due diligence and you go through and have a full screening eye exam in which she performs very well, excellent vision, excellent pressures, a normal anterior segment and posterior segment exam. So the question is for the optometrists in the audience, and I know we have optometrists here, we have GPs here, and we may also have surgeons on the call. So I am trying to cater to the different perspectives, but starting kind of from an optometry or a GP perspective, what else might you want to know about this patient in seeing her in front of you?
General health, medication.
General health, medication.
General health and medication, yeah.
So she's very healthy. She has no previous history of issue. She's not on any medications.
How long has this been, this condition?
She has noticed the droopy eyelid. That's a great question. Thank you. She's noticed the droopy eyelid for about 2 months now, 1 to 2 months. Started off a little bit more minor, maybe happening occasionally, but now every day she notices this droopy eyelid. Okay, and any questions?
Was it gradual to begin with, or was it, it's quite a marked ptosis?
You're right. It was more gradual. It wasn't this marked at its onset. So initially it was very minor. She hardly noticed it.
Pupillary response?
Very good question, and we'll get to that.
Pupillary response.
Yes, that question was a pupillary response, and that is an important piece that we'll get to.
From the webinar side, we have motility and pupil reaction from Christina.
Christina, you're right on point. That's excellent. So that just brings us to this framework. So this is probably the most important slide of this entire talk. Quite simplistic, but purposeful, and I'll be quite repetitive in bringing this slide back throughout the course of this talk, because these are the three pieces that you'll see in any of my notes. For every patient that comes in with a ptosis, I am checking these three things no matter what.
There's another question from the webinar, from the people sitting at home. Is there a history of any weakness? I don't know whether they mean general weakness or eyelid.
Right. There is some history of weakness more recently, a little bit of intolerance at the gym that she's noticing, and we'll get more information about that, but that was a really poignant question. So good on whoever posted that. So back to these three pieces: extraocular movements, pupils, and fatigability. This is the framework I use. Even before I get into a detailed history, I often make sure I start with these three pieces. I check the extraocular movements, I check the pupils, and I get a sense of if there's fatigability, because this will allow me to capture almost all of the life-threatening issues related to ptosis. And you don't need to know exactly how those extraocular movements map to a cranial nerve palsy. You just need to decide, is something abnormal or is it relatively normal? So this is our patient. I had her, because I'm the one taking the photos, so I had to have her hold her eyelids up. It's not the best ocular motility test, but you can see in primary gaze, it's quite well aligned. On left gaze here, it's a little bit hard to see in this photo, but she does have a little bit of an abduction deficit, maybe a -1. And then for sure, in up gaze with the left side, we're definitely seeing some issues with limitation there.
Tanya from home is saying, or asking, is there fatigability?
Very good question. And so we'll get some more information next, but that's exactly right. And based on our framework, that's what we want to be asking about. During the extraocular movement test, you can start to look for signs of fatigability. So what you can do is just, as you're having the patient look towards the lateral gaze, for example, ask them to hold it there. And you may see that they're struggling to have that sustained contraction. And initially, for example, our patient may have been able to achieve sort of a higher elevation, but if we asked her to continue holding that gaze, she may not be able to continue holding that gaze over time. And so if you slow down your test, or if you sort of push patients, we might be able to suss out some fatigability. This is some more information, and this relates to some of the questions that have been posed. She does endorse that she's noticing the eyelid come down significantly worse at the end of the day. And she doesn't actually show photos, but I ask her to show photos because a lot of patients are taking photos and sometimes they feel shy to show them, but they're quite important, especially in a marked ptosis such as this, to see what the timestamp is on those photos and how drastic is that difference. Because some patients may say that there's a drop in the eyelid as the day goes on, but that drop is only maybe 0.5 millimeter, something barely noticeable. Whereas for someone like her, the ptosis that she has on waking up is maybe clearing the visual axis and then all the way down, and that's quite marked. One important piece here, and I pose this question to you, is why does she not notice any double vision? What are some of the possible reasons you think that this patient is not seeing any double?
The eyelid's covering the other eye, so she's only got monocular vision.
That's totally correct. So the response, which is correct, is that her eyelid is coming down so far that it's essentially creating it's eliminating the double image. She's monocular. But also we saw that she was quite aligned in primary gaze, and it was really that the misalignment happened more with up gaze. And most people actually don't necessarily look up that often. In fact, we usually tilt our chin up when we're looking up. And so when people have deficits with up gaze, they're less likely to notice it, especially if it's subtle. Down gaze, much more likely to, because we're reading. We have our whole world that exists often in down gaze and in primary gaze, but that would be another reason that she isn't noticing it. And that is a very important point. The last thing she sort of offhandedly mentioned in my visit with her that I didn't pick up on at the time, but then I later called her, is that she hasn't been eating as much and she finds herself exhausted and unable to go to the gym. Does anyone have any idea why we might be concerned about that? Whether we should be concerned about that? Is that irrelevant? What are your thoughts on that?
It seems like she's very fatigued as the day goes on. The muscle or the eyelid obviously starts drooping.
Right.
But it's the rest of her body as well, by the sounds of things.
Exactly. What about the eating? Why would that be affected? Can you think? Does anyone have any idea? In the end of the day, yeah, in the evenings, why would, or even just eating throughout the day?
There's a few comments from online, but I think they might be spoilers because they're very keen to try and start making diagnoses. They're pointed out, so Farhan has pointed out that ptosis is blocking the binocular vision. That
Correct.
you agreed with that?
Yes.
And one of them, well, two of them have said possibly, do you want them to
Yes,
guess
you
yet?
you can guess. Yeah,
We can guess.
I think that's
Great.
fair.
Possible MG, myasthenia.
Correct. Yeah, so definitely on the right track. And I think that it's very much the fatigability that we're noticing here is a very classic piece that we want to associate with myasthenia gravis. Let's say that you didn't know of the diagnosis of myasthenia gravis. You can't remember. There's so many things to keep track of. You're not in the oculoplastics or neuro-ophthalmology worlds, but how are you going to know that something's wrong? So we're not going to, I think, focus as much on diagnosis, even though it's important, but go back to the framework of what we had to check in this patient. So we checked the extraocular movements. Pupils, you'll have to trust me that her pupils there was no anisocoria, they were equal, reactive, I had no concerns. And then fatigability. Fatigability, we don't always necessarily have to get on our examination. A lot of the time, especially in a GP office or optometry office, we're getting the fatigability piece from the patient, from photos, and how they describe their symptoms. So that brings us to the first of the three diagnoses that we cannot miss because they are associated with life-threatening consequences. So what is it about myasthenia gravis? Yes.
Everyone's very keen to know, why was she not able to eat? Did she have dysphagia? What was it? Or can you?
Totally. So the myasthenia gravis affects skeletal muscle, and it affects the transmission from the nerve to the muscle. And we have skeletal muscle throughout our oropharynx. It's actually quite a muscular process to be able to swallow. We have to take food, we have to move it around with our tongue. Our tongue then has to direct that food to the back of our throat, and then that food has to go down the esophagus. And that's actually a very muscular process, even our jaw muscles to chew the food. So in the same way that she has fatigability with her eyelid muscles, she also has fatigability with chewing. The patient might actually say, I'm able to eat just fine for a few minutes, but after a while I get tired. I find I need more water to help me swallow, so I need to pause. And the resting is restorative in patients who have myasthenia gravis. So they will often say, it's fine though, I'll take a little break and then I'm able to get back to eating. It's not a big deal. And because it's not always very acute onset, patients may not even realize that they're making these little maneuvers to compensate for what they're doing. And that was something I missed on her sort of offhanded remark. And it wasn't until later on when I was following and thinking about her diagnosis that I realized that that might actually be something worrisome. So the reason that myasthenia gravis is important for us to notice and for us to diagnose is not only because of the swallowing risk, so choking is obviously a risk to people, but also the respiratory muscle. So these people can go into something that's called a myasthenic crisis, and their shortness of breath develops very, very quickly, and they need to be rushed to the hospital and sent to the ER. It's rare for us to encounter that, but if you were to see a patient who was really struggling to breathe, they might almost look like they're having almost like an asthma attack, very short of breath. That is something that needs to be seen right away because these patients are often already at the end of their compensatory abilities and they often need to be intubated. So that is why it's important. What would you do if you were the optometrist or GP? We're going to pause for a question on the webinar.
Faria says, wouldn't myasthenia gravis normally cause bilateral ptosis? Why was it unilateral?
That's a good question. So myasthenia gravis actually is known infamously for not really following a clear pattern. Sometimes it can be the right eyelid that droops. Maybe 2 weeks later, it could be the left eyelid that droops. Sometimes it could be both eyelids. So I mentioned this concept of fatigability as being a hallmark of myasthenia gravis, but equally so, variability is a hallmark of myasthenia gravis. And so I wouldn't say that bilateral is necessarily always what we see. In fact, I see a lot of patients with myasthenia gravis that present with unilateral ptosis. In terms of next steps for the GP or the optometrist, in our patient, I would say refer to neuro-ophthalmology or ophthalmology. It depends on who you have sort of in your local area that you feel comfortable referring to and what their scope is. And very important, I would say, for documentation and for the patient is to warn the patients about breathing or swallowing difficulties. So in this patient, it seems less urgent. Well, she has a droopy eyelid, she has a little bit of double vision, but no, if she's being followed up at a 2 or 3 week interval, it's possible that she could decompensate, and she needs to know what the symptoms she should look out for that are important. So I do always warn. And then what does an ophthalmologist do? So what happens when you refer them? What is an ophthalmologist going to do differently? What happens to the patient next? Well, we sometimes do, and these are some of the tests that I tend to err towards because they're not too complicated to do, but we'll confirm some of the evidence of fatigability. So the up-gaze test is definitely a test that anyone can do in their office if they have some time. But essentially, the idea is to tire out the levator. And the way that I would administer this is if I have a patient in front of me, let's say Miss Jones, I'd say, Miss Jones, I am going to have you look at the tip of this remote, and Miss Jones has to keep her head straight. That's why in this diagram we can see that someone is reminding her that she can't just lift her chin up. Otherwise that would sort of negate the test. So I would put my hand on Miss Jones' head, and she would be looking up towards this target. And really, I want her to be looking up for at least 45 seconds. It's quite a long time, and it's okay if she has to blink. And I'll say that, Miss Jones, it's okay if you need to blink. As soon as you're finished blinking, though, you need to immediately focus again on this target here. And what you'll see during this up-gaze fatigue test, often in patients with myasthenia gravis, is that in real time, that eyelid will slowly start to go down. Even when the eyelid started off in a good position, it will slowly start to come down. It becomes hard to do the up-gaze fatigue test in someone like her because the eyelid is already sitting quite low, but I did do it and I should have videoed it, but her eyelid came all the way down during that test. So we could see maybe 2 to 3 millimeters palpebral fissure here, and then there was 0. Another simple test at one of the clinics I worked at before is that, and we have it at Clinica, is just to do an ice pack test. And so we'll just hold an ice pack to the affected eyelid, and over the course of 2 to 5 minutes, we should see some reversal in the eyelid height. Usually we're looking for a lift of about 2 millimeters or more. What else am I going to do? You've referred to me, you've referred to an ophthalmologist. What am I going to do for this patient? So the most important piece these days in terms of testing is blood work. So in the past, in textbooks, you read a lot about edrophonium or the tensilon test. That's pretty much not used anymore. There are a lot of possible side effects, dizziness, problems with the heart rate that can happen. So most of the time we're diagnosing patients with myasthenia gravis by ordering an acetylcholine receptor antibody or an anti-MuSK antibody. Again, stressing the importance of what to look out for. And then we're referring and working in close tandem with a neurologist, because the neurologist will take that patient and then make sure that all of the systemic workup that needs to be done is being done. An important piece of the systemic workup is a CT chest, because a lot of patients who have myasthenia gravis have issues with their thymus. And the thymus is almost like this endocrinology It has both endocrine function and it also has immune function. And many patients who have issues with myasthenia gravis may also have issues with their thymus, particularly a thymoma. So that's why we order a CT chest to look for thymoma. The patient that I was showing in my case, she had a thymoma, and so she ended up having surgery to remove the thymoma, and her eyelid height did not completely resolve, but has improved significantly since then. In terms of treatment, there are different types of treatment that you may see patients on. A neuro-ophthalmologist may often start patients on this treatment, and then it's managed, again, in tandem with the neurologist. But the reason it's so important for us to be involved is because we're often looking at issues like the ptosis or the diplopia to determine whether the patient is actually responding to those treatments. And we've gone through a little bit of this already, but this is sort of a summary of this disease. Myasthenia gravis is an autoimmune disease. The reason it's occurring is because there's an antibody that our body naturally makes, but it's attacking our tissues incorrectly. It's attacking us in the part that connects the nerve to the muscle, and that leads to an inability for a muscle contraction to be sustained. So the patient's often able to initially initiate that muscle contraction, but if you ask them to sustain that muscle contraction or you ask them to repeat that muscle contraction, that's when you start to detect the myasthenia gravis. We talked about why myasthenic crisis is so important for us to identify. Yes, I'm happy to be.
Parul Shah says, what is the prevalence? What is the prevalence of myasthenia gravis?
In the total population, I think it's quite low, like less than 5%. But in patients, there's a bimodal distribution often. So they often say it might be a young woman or an older man as their classic stereotypes, but it can happen to anyone really. But that's a good question. We'll have to ask ChatGPT.
Oh, no, please don't. Why does ice pack work in MG patients to reduce ptosis?
That's a good question. So it has to do with slowing down the degradation of the acetylcholinesterase. So this is an enzyme that basically breaks down acetylcholine. Acetylcholine is the neurotransmitter that goes and works on the muscle. And if we can stop that enzyme that breaks down acetylcholine, then we'll have more of it existing in the synaptic cleft, and therefore more muscle function can be retained, I should say. And about 50% of patients with myasthenia gravis first present with ocular symptoms. So I think that's really important because as an optometrist, you are most likely to see a first presentation of myasthenia gravis. And then 80% of patients progress to generalized myasthenia gravis within 2 years. So I think that is also important in terms of counseling patients because patients might ask, well, is it just the eyelids? Is it just my double vision? But these patients need regular follow-up, often coordinated by the ophthalmologist or the neurologist, because just because they have only eye symptoms doesn't mean they cannot develop some of these more serious issues. And notably, if more than 2 years has passed, if it's been 10 years and they've only had ocular symptoms, that's actually very reassuring. They're much, much less likely to go on to develop generalized. So that's a reassuring piece. Okay, so now for sort of if there are any surgeons in the crowd, if our patient comes in and she's maybe 2 months into her treatment, she's very keen for surgery. Remember, that's what she came in for initially. She's mostly just bothered by how this looks. She's in university and she doesn't like this. What do we tell her? Can she have surgery? Should we tell her to avoid surgery? What are her options? Does anyone have any idea? It's okay. If you don't, you can take a gander.
First of all, I wanted to just ask about her mother.
Yes.
Because her mother had the same operation.
Yes.
And did we look into the mother's history? Was she had any leukemia of any kind?
I really like that line of thinking. It was her aunt, but her aunt actually didn't have her. It's interesting. Her aunt had thyroid eye disease, which is in itself an autoimmune disease. And so she didn't truly have a ptosis. She actually had a retraction repair. But it's a good point because as an autoimmune disease, many of these run in families, whether or not it's myasthenia gravis or some other autoimmune disease. So that's very important. Okay, I will answer this question in terms of what I would tell this patient. So initially, she's just presented and she's just started her treatment. So I definitely would not be operating on this patient because the treatment, including the medications that we give her, can improve the ptosis. So we wouldn't want to go intervening anatomically if we expect some improvement with medications.
I think someone at her home has actually answered exactly what you've said. They said, would it be actually preferable to treat the MG rather than ptosis surgery? And you're saying yes,
Definitely.
treat it first.
For sure. We want to avoid surgery. Surgery on a myasthenic gravis patient is challenging, because, especially if there are ongoing fluctuations. So I do operate on patients who have a history or are still being treated for myasthenia gravis, but I have to bring them in maybe about 4 times to make sure that my measurements of their eyelid height are relatively stable. I also ask patients to take photos in the morning and at the end of the day, because I want to see it at its best and at its worst, so that I know where to aim the eyelid height. I also, I basically set expectations differently in these patients than I would for a patient who does not have myasthenia gravis. I say that it's hard to predict the longevity of this repair. I also won't necessarily aim for the highest and most perfect symmetry sometimes, because I want to account for variability. But these are all discussions that I'm having at least a year to a year and a half later. So it is a bit unfortunate, but as I mentioned, this patient actually had quite marked improvement just by starting pyridostigmine. Okay, so any final questions about that first case? Just a little pause. No. Okay, well, you can always circle back. So we'll move on to the second case. This now is a 54-year-old woman. She presents to her optometrist because she feels like her left eye just looks bigger. And she's noticed this for a while. She's just really busy, and she's finally coming in and she says, "Why is my left eye bigger? What can I do? I don't like the way that this looks." Again, you go through your normal exam. Everything is fine in terms of visual acuity. Anterior segment and posterior segment exam are within normal limits. She did mention that she's a smoker, but other than that, she's very healthy and not on any medications. Is there anything else that you might want to do or that you notice in this patient?
The left pupil looks more dilated than the right.
That's perfect. Yeah,
Oh.
very astute. So the comment was that the pupil on the left looks larger than on the right.
Right eyelid also looks thicker and heavier. The right eyelid seems to be drooping and it's thicker and heavier.
Yes, that's a good pickup. I would say that for most of us, just on a cursory glance, wouldn't necessarily pick up on that very minor degree of ptosis, but I agree there is ptosis there.
Do you want to know the diagnosis?
No.
No, not yet.
But I like that someone has it there.
Someone's already probably got the right diagnosis from at home on the webinar.
Perfect. So you're on the right track. Before we get to the diagnosis, I just want to hammer home this idea of framing every patient not as what is the diagnosis, which is important, but what is your approach. So in very basic terms, we have a patient in front of us. We notice there's a ptosis. We channel back to this Clinica Academy lecture that we decided to listen to, even though it's after work and we're tired. But this woman kept going on about 3 things that we need to check in every patient who has ptosis. Doesn't matter what we're thinking about the diagnosis. And those 3 things were extraocular movements, pupils, and fatigability. Interjection?
No, there was just another clinical observation from your photos, if you'd like to just pop back, that says ptosis and elevation of the inferior lower lid on the right eye.
Very astute for whoever noticed that, because it is
Kinney.
The lower lid does also come up, and sort of they call it like a reverse ptosis, and that is a finding that leads to our diagnosis as well. But focusing just on the framework, I am going to go through these 3 things in my patient because that patient has ptosis. That's all I need to think about. So I check her extraocular movements and they're totally normal. I don't see any deficits. Pupils, we've already decided that we're seeing an anisocoria. The pupil on the right is smaller than the pupil on the left. And fatigability, we're getting this by our history. We ask her, well, are you noticing any drooping of the eyelid that gets worse as the day goes on or as you become more fatigued? Do you have any diplopia? Question.
You mentioned the pupils about the different sizes.
Yes.
You didn't mention the pupil response to light though.
That is very good. So the pupil response to light is within normal. So we don't see any sort of obvious relative afferent pupillary defect, but because we see this anisocoria, we decide that we are going to check the pupils, and that's probably what you're maybe getting at, is to check the pupils in light and in dim. So this is one of the tests that we do when we are thinking about a Horner's. Essentially, in a bright lighting condition, you ask the patient to fixate on a target in the distance. It's very important that you're not asking them to fixate on a target close up because their pupils will constrict and that will kind of mess up your measurements. If you have a pupillometer, which is a great device, and this will give you a great measurement and an accurate measurement, but I find the rulers that have the markings for the pupils to be quite good. And so if we measure the right side, and the left side in bright lighting conditions, I was measuring 2 millimeters on the right and 3.5 millimeters on the left. Don't worry, this ruler is not aligned for this actual patient, but this is accurate in terms of what she was presenting as. And then in dim lighting condition, we can see that the pupil is 2.5 millimeters on the right, but much more dilated on the left. And when we do subtraction to see what the difference is between the two sides, the difference in the bright lighting conditions is 1.5 millimeters versus the difference in the dim lighting conditions is 3.5 millimeters. And so for Horner syndrome, it's classic that the difference between the pupils is more pronounced in dim lighting conditions. So that's really nice, that's important, it's on your exams, and it's good to do, but often we're very busy in practice, especially if the optometrist is the first line of defense. I think just noticing that there is an issue with the pupils, anisocoria, that can be all that is enough for you to be concerned about this patient and to know that you need to think more than just the aesthetic side or lifting the eyelid. That brings us to our diagnosis, which I think someone has already come to.
About 20 of them online have come up with that diagnosis.
I love
had
it.
to hold back.
Okay, thank you. You guys are very smart, and that's excellent. Thank you so much. So why do we want to identify this diagnosis? We always hear about Horner syndrome, but why is it so important that we pick up on Horner syndrome? Well, there are actually two diagnoses associated with a Horner syndrome that are life-threatening. So the one we're more familiar with is a carotid dissection. If you'll recall, the carotids are these vessels, the big vessels in our neck that take the blood flow from our heart to our brain. And when there's a dissection, we're interfering with that blood flow, and that could lead to hemorrhage in our brain, and that could lead to death even within hours or days. So it's quite an important one to pick up. I would say that Horner syndrome is more of not that it's more important, but it's more important that you can identify a patient who might have a carotid dissection than maybe a myasthenic gravis, where you probably have a few days or weeks to play with for the most part. This one is, you need to know, and you need to know what to do with this patient. So if you're the optometrist or you're the GP and you notice an anisocoria and you notice that on the same side as the myotic pupil, you see a little bit of ptosis, it's usually a very small ptosis, around 2 millimeters, that's enough. You don't necessarily need to do the light and dark measurement. You don't necessarily need to do anything more involved than that to say, this is concerning, I'm worried about this patient, I'm going to refer to neuro-ophthalmology. And what will the ophthalmologist do when they see this patient? So we're thinking about that patient that presented to us. Remember, she had this difference that she had noticed for many years. She wasn't particularly worried about it. It wasn't new. So there's not big urgency here per se, but we still need to check it. So the ophthalmologist will probably do that test of light and dark. They'll also administer aproclonidine often. I usually use 0.5%. And this is a very low risk test. You might come across the cocaine test. I've never seen that done, but aproclonidine is often used. And what we're looking for is a reversal of the anisocoria. So the pupil that was miotic will dilate, and the other pupil will either not really react or maybe even constrict. So that's what we're looking for. You do have to wait, so don't expect that reaction right away. Have the patient wait for about 30 minutes. And if you do see that reversal, that is very suggestive of Horner syndrome. One thing I will mention in regards to this test, this aberclonidine test, is that it doesn't work in acute Horners per se. So if the patient has a reason for acutely developing the Horners, which we'll get to, and you perform the aberclonidine test, you may not see the reversal of anisocoria. And this is why it's so important actually to really listen to the history of the patient for Horner's patients. And then the other piece that we would often order is an MRI brain and cervical spine. I really want to emphasize the cervical spine piece because I get a lot of referrals where an MRI brain has been done in the workup of a Horner's, but they're often forgetting to do the cervical spine piece. And we have to remember that the sympathetic chain is traversing sort of from the level of our cervical spine or neck up into the brain. And so we need to capture that whole piece. So in our first patient that we had been talking about, when we had done the CT scan, this is sort of the abnormal area. That's a Ptosis tumor. If you remember, she was a smoker. And so this is a type of lung cancer, and it can be quite severe. So it depends on when it's picked up, but it is a life-threatening type of lung cancer. It's not acute. But because you've identified the anisocoria, you've identified the pupils, and you've identified the eyelid, you need to initiate some sort of pathway with workup. Okay, let's get back to some of the surgical thoughts on this patient. So she's keen for eyelid surgery. What do we tell her? What would you do? What do you think if you're a patient?
Stop smoking.
Stop smoking. That's a good point. I agree. Let's say this patient had her Ptosis tumor removed and she's doing remarkably well. Often the ptosis does not actually resolve because there's been damage that's long-standing to those sympathetic fibers. Is it reasonable? Would we go after a ptosis like this? Are any surgeons willing to go after a ptosis that's this small of a degree?
They're very quiet online about committing themselves on what they would do surgically.
Fair enough. So in my practice, I do perform surgery for small, subtle degrees of ptosis. I need there to be at least a 1.5 millimeter difference for me to consider going after it. But I do find quite a good result in using a posterior ptosis approach and being quite subtle. I counsel these patients differently. I make sure that I set expectations. Same with the myasthenic gravis patients. I tell patients when there's a small degree of difference between the eyelid position, it's actually harder to achieve the outcome.
The surgeons are committing themselves now. Some of them have said yes, some of them have said no, another one has said no, and then Eduardo has said MMCR.
Yes, I agree. I definitely wouldn't be pushing this patient into doing surgery. I would be very open about what is realistic. So I would counsel that unlike in other surgeries, I might be able to give you a certain realm of certainty that I can achieve a really nice symmetric result. One of the risks of doing a small degree of ptosis is that we can overcorrect. And I often show patients what does it look like when we overcorrect, which is lifting up the eyelid too high and retraction. And showing that superior scleral show looks a lot worse. People, when they're talking to you, are more likely to notice an asymmetry when there's a retraction than they are for a small degree of ptosis.
Where do you put the skin crease?
So because I'm doing the posterior ptosis approach, I don't really worry.
It just happens naturally.
It happens naturally and it tends to work out just fine. I like that approach for these small degrees, and that's the only way I will go about doing a case like this. I would still kind of have the patient come back maybe once or twice to know that they're sort of committed to going through it because there is a little bit more risk involved. But I do go after these sometimes. One thing I will point out to the patient surgically is that we're not correcting the lower eyelid position. That's come up again because of the sympathetic fiber damage. We're not going to be addressing that with our eyelid lift, so technically we're not going to necessarily be able to achieve perfect symmetry. The palpebral fissure will still be smaller on that side. Okay, so this is case 2B. Looks really similar, right? It's the exact same photo, but let's imagine that this is a different patient, but presents exactly the same way. So the only thing that's different here is her history. So let's talk about her history and what features on her history make us concerned. So this patient, she comes in to your optometry office or your GP office, and she was rear-ended in a car accident yesterday. It wasn't a high impact collision, but she was rear-ended and her neck sort of had this quick flexion and she has some whiplash. She's complaining of sort of severe pain in her neck, but she's managing it. She feels with Tylenol, and she's sort of holding her neck during the exam, but still able to talk with you normally. The reason that she's come in to your sort of urgent walk-in clinic or your urgent optometry clinic is because she noticed 2 episodes where there's been dimming of her vision. And it actually goes almost completely gray and she can't see, but it comes back completely.
A question from online, from Yessa. Could you kindly list the most common ophthalmic and non-ophthalmic symptoms for a Horner's? I expect you're going to do that in a minute, aren't you?
Yes.
Great.
Ophthalmic and non-ophthalmic symptoms of a Horner's. Yes, we do come back to that a little bit. More of the red flags, the more worrisome things, because actually there's a whole slew of things that could technically be related to Horner's that have to do with intracranial processes, and they have many different subcategories, but we're going to keep it into the big categories. Okay, so in this patient, she had 2 episodes of dimmed vision, and the reason that she's in your clinic today is because she wants to make sure, you know, she covers herself with her insurance and that she reports maybe there's been some damage to her eye as a result of the accident. So what are you thinking about this patient? Are you concerned? What are you going to do with your examination?
So let me think.
Visual field test. Her visual field test is actually okay. It's fine. Yeah, that's a good thought. So we're still, again, yeah, so same, the pupil, there's no RAPD, but we're again looking, we can consider light versus dark. And I'm going to just bring us back to this. Without getting caught up in the history, again, we know that we're just going to think about extraocular movements, pupils, fatigability. We know that the pupils are the only piece that we're seeing after we do check all of these things, and we know that it's abnormal. But here's where the history comes into play a little bit more. This is a red flag feature, which is that, yes.
Oh, you just got there before. So online, Christina has suggested it may be a carotid dissection.
That's perfect, Christina.
And Selena's incredibly concerned. They want an immediate CT or MRI, and they want you to look at her optic nerve head.
Very good. Her optic nerve head was actually normal at that stage, but I do definitely agree with that level of urgency. That should have lots and lots of exclamation marks. Hopefully the message was in caps lock, because this is the patient that you can't miss. This is one that needs to be picked up on. That patient of ours who came in quite nonchalantly saying, I've been rear-ended, I have some neck pain, you're skipping all the next steps and you're sending that patient directly to your A&E, and you're requesting that they have urgent vascular imaging done, CTA or MRA, to rule out a carotid dissection. Now, if you're an optometrist, it's reasonable to coordinate with the ophthalmologist, tell them why you're very concerned, but this isn't a patient that you want now waiting again necessarily an ophthalmology casualty. This is someone that you need to advocate for your patient and say, I'm really concerned this could be a Horner's. Don't worry about the embarrassment if it doesn't end up being what you think it is, because it's more important that you don't miss it, and that's more important for the patient. So I just want to stress that. So different approaches. I'm curious to know what people would do if they've ever encountered a patient like this, or when they're very concerned. Do they have a way of getting in very quickly? Have you ever, if you're an optometrist, do you find there's much success in just sending a patient directly to the ER with a letter, or is that unlikely to yield any results?
I think you remember I mentioned a case earlier on.
Yes.
Left eye totally drooped, and then I sent her straight to the hospital. And it was actually an emergency with a critical letter, and they saw her straight away and operated on the same day.
That's good to know.
It was the carotid artery
That-
aneurysm.
That's a great pickup, and exactly right. So this is a good story and a good case for, I think, knowing when you can skip the hierarchy and identify something and trust your gut or trust your exam findings, even if you're not 100% sure. If there's something off that you know, the pupils are off and there's red flag features, which we'll talk about, but it was really the neck pain and the transient visual loss. This is the patient that needs to go to the ER. Okay. So 2 pathways for Horner syndrome. I presented exactly the exact same image, but the only difference between those 2 patients was their history. And so this is where history really matters. So if there's pain associated, she had neck pain. If it's acute onset, she noticed this new change just after the car accident that she had been in, and she had transient vision loss, very concerning. That's going directly to A&E. Whereas the other patient, the first one, we're sending sort of semi-urgently to an ophthalmologist because we still need to rule out other life-threatening things that are not plus or minus a few days, but like such as the Pancoast tumor, which can still be important to identify. And just some general facts about the Horner syndrome. So we talked about how it's caused by a disruption of the sympathetic nerve supply to the head and neck. Classically, in textbooks, we read about this triad of ptosis, meiosis, anhidrosis. Anhidrosis, I'm curious if anyone ever really sees anhidrosis. I maybe had one patient that I convinced myself that side had quite dry, cracked skin because of the lack of sweating on that side, but never do I really hedge my bets based on that piece. And then a painful acute onset Horner's is a carotid dissection until proven otherwise. So there are many other benign causes of a Horner's. So the patient may have had some sort of spinal surgery to their neck, or they may have had a thyroid surgery, or they may have had iatrogenic interventions that could have damaged the pathway. Some proportion of Horner's, we never really identified why they developed the Horner's, but that should not be your go-to. That's your final that's the final diagnosis that you can give once you've ruled out all of these other pieces because they're so important. Okay, so I'll pause there again if there are any questions that come up in relating to the Horner's. Yeah.
Everyone's happy. They're all
Okay.
stunned.
Oh, we're just gonna do a
Sometimes when I done a contact lens check and I haven't got an optometrist near me, I have noticed it and I referred them straight to Moorfields. So I don't know what happened after that.
That's good. Well, hopefully, I'm sure they're
Only
doing
about
some of
6
this.
o'clock.
Yeah, of course. It's always at 6 o'clock that that patient shows up.
That's little, I noticed it and I just referred
So to the local ophthalmology, or you would refer there, but there's people from all over the world
Yeah.
and country. So your local ophthalmic A&E.
That's perfect. Yeah, and I think it's reasonable to quickly have a chat and say, oh, you know, I've just noticed that your pupils look a bit different in size. Have you noticed that before? Many patients will know. They'll say, oh, I've had that since I was 20 years old. It's always been like that. Other patients, you know, they might say, no, I've never noticed, or they have other symptoms. But I think your approach is perfect.
There's another question online. Which anisocoria aren't you sending to the neuro-ophthalmologist? In other words, which ones do you accept as normal from Constans Mulders?
I like that question. Anisocoria can happen in patients, for example, who have a history of uveitis. We see poor reactivity. And if I know the patient has a history of uveitis, if I see other features such as transillumination defects, that could suggest a history of herpetic involvement. I'm not worried about that anisocoria. An 80s tonic pupil, I'm not often sending to a neuro-ophthalmologist, but it's reasonable too if you want to have that reassurance. Yeah.
This very week, I had a 6-month-old child with the parents had suddenly noticed the anisocoria. Is there anything I should have done other than examine her fully, do her refraction, look at the back of her eye?
Ah, I
And she's
love this
completely
question.
normal, happy baby.
Wow. So we do, even if we see any suggestion of anisocoria, did she have, was there a ptosis?
No ptosis, and they think she'd had it for a while.
And any difference in the eye color on that side?
No difference in the
No.
eye colour, no. Hey, yes,
Yes.
congenital horniness. Hey, I've forgotten about that one.
So that's a tough one, honestly,
David Bowie.
actually. I think that it's reasonable to potentially monitor, but it wouldn't be unreasonable because the ptosis can be so subtle and difficult to evaluate in a young child when it is a subtle ptosis, to consider maybe doing imaging or at least have a pediatric ophthalmologist.
She's coming back to the pediatric ophthalmologist.
I like it. I approve. Well, okay, perfect. So let's move on to, oh, I gave it away. This is our last case. So this is one that we're probably a little bit more familiar with in terms of it being something to worry about. But this is a 66-year-old, and he notices his eyelid drooping as of yesterday. Okay, so fairly acute onset. He has a severe aching pain behind his eye. He's tried all of his home remedies, his pain medications, nothing is touching it. And he does notably have a history of diabetes, hypertension, high cholesterol. What do you want to know about this patient? What will you do next for this patient? What are your concerns?
I think I'll send him straight to the ophthalmologist department with the pain behind his eyes and his eyes drooping overnight.
Yes. So I agree with that. This is already something that we're worried about. We know that we're worried about this patient.
Immediately refer is the comment from online.
Perfect. So I like the way that everyone is thinking. I'm just going to go back just to be very pedantic before we move on with the rest of this case and to think about these three pieces. So you have your patient in front of you. Even though you have the history and you can kind of get a gestalt, you're going to document these three things: his extraocular movements. So we can see that the eye is down and out, very classic of a third nerve palsy, which is what we're already sort of thinking about here. And then pupils. We want to make sure that we're checking the pupils and that we're looking at the difference between the pupils. So does anyone see a difference between the pupils? Yes. So we can see that the left pupil is larger than the right pupil. And then fatigability. No real fatigability. He doesn't endorse anything. But those are the two pieces. And we're going to make sure we check that. Even though we're already worried, we're going to put that in our notation.
Webinar chat saying risk of stroke, aneurysm, third nerve palsy. Yes, we know it's a third nerve palsy. Is the blood pressure controlled?
Very good question. So we didn't check the blood pressure at the time, but that's a very good point. Let's move on. So this is exactly what you're worried about, what you mentioned in the webinar. Why do we even want to identify third nerve palsy? Why is it so important we pick up on it? It's because of the association with brain aneurysm, and this is the life-threatening piece that we need to be able to pick up. So what are the steps? This, again, has sort of two pathways similar to the Horner's in terms of how urgent and how worried you need to be. So the pupil involvement makes us very concerned. This is a patient, again, we're skipping over the hierarchy, we're skipping over waiting for referrals to get accepted, and we're sending this patient directly to A&E. They need an urgent CTA or MRI to rule out an aneurysm or some sort of other internal hemorrhage or tumor that's expanding. This is an important piece, is the pupil involvement. If the pupil is not involved, you have a case to send this patient urgently to an ophthalmologist or neuro-ophthalmologist. I think that's very reasonable. It would not be wrong to just not even worry about the pupils and say, I'm going to send this patient to the A&E just to cover your bases. And in fact, when I see any patient with a third nerve, this is in my practice and the colleagues that I've trained with, regardless of whether the pupil is involved or not, we are sending this patient for a CT-CTA. And there's some studies that support that this should be our approach. Obviously, depending on where you practice, that might not always be feasible. But in my practice, I still am sending a patient with a third nerve palsy most times for a CT-CTA, unless it's, you know, slam dunk in terms of vascular risk factors. So we talked about the importance here of identifying what is the blood pressure, how is the diabetes control, because those pieces can affect the flow of blood and the basically oxygenation, which affects third nerve palsy. So we want to make sure that these pieces that we can control are being controlled, and we coordinate that with the GP. If you are following a patient with a third nerve palsy, you should see an improvement every couple of weeks. If you're not seeing some degree of improvement, then you need to rethink your diagnosis. This may be a patient where I held off on doing the CT-CTA and I didn't see improvement, then I definitely want to do it, the imaging. Question.
Can you take this long comment? The meeting schedule is about to end. Action items for this meeting: refer the patient to the ophthalmologist department immediately due to the acute onset of eyelid drooping and severe pain behind the eye. Document the patient's extraocular movements and pupil differences in the notation. Send the patient directly to A&E for an urgent CTA or MRI to rule out an aneurysm or other internal issues. I think that's what you've just said.
That's perfect.
Exactly.
We got it.
Fantastic.
Thank you. Thanks for coming.
Well done, everybody.
How much time do I have, by the way? Are we done? Close to the end.
Sorry, I'm not with my clock at the moment. We have 4 more minutes.
Okay, fine. We'll rush through the very end, but this is the most important part. I didn't expect everyone to be so engaged. This is amazing. Thank you for being everyone so engaged. Third nerve palsy facts. Takeaway: painful acute third nerve, dilated pupil. It's an aneurysm until proven otherwise. We're sending it directly to A&E. Most common cause is microvascular ischemia. You're going to help that patient by making sure they're seeing their GP to manage those pieces. These are the red flags. Generally, if you see a ptosis and any of these kinds of pieces are mentioned on the history, then we need to be concerned and pause. New headache, neck pain, pain behind the eye or ear, recent car accident or neck manipulation. I have seen a carotid dissection in patients who have been doing yoga and patients who have had chiropractic manipulation. Though it isn't just a big car accident, it can be quite benign things in relatively young, healthy people. Breathing and swallowing problems, and ptosis worse at the end of the day. Okay, what should I do, Jane? What do you think? Should we
I think we need to know if people are happy if we run over about 5 minutes. From the audience here in person, they all say yes. And the webinar?
Okay.
Yes, we can.
Let's get right into it. So,
yes, happy. Yep, go for it.
So we're shifting now. We're shifting gears into the second part of our talk. Just talking about the more common ptosis that you'll encounter much more frequently than the other life-threatening causes. This is a patient with aponeurotic ptosis, and so I'm going to skip kind of having you give your input and sort of point out what I see. Classically, with an aponeurotic ptosis, we're seeing a very high eyelid crease. So the eyelid crease is measured from the eyelid margin up to this crease. Normally, it should measure maybe anywhere from 8 to 10 millimeters. If we held a ruler, up to her eyelid there, that would measure maybe like 25 millimeters. We're also seeing some other pieces where she's compensating. You can see that there's lots of wrinkles in her forehead because she's evoking her frontalis muscle, and her eyebrows are really high up because she's really trying to use her brows and her frontalis muscle to help lift her eyelids so that she can see clearly out of the eyes here. This is her before and after ptosis surgery. She's still lifting the brows quite high. And we'll actually see, because this is her, I think, only 10 days after she had her ptosis surgery. Over time, those brows will come down. And I want to just, I'll show a video in a moment about how the brows come down and why it's important to think about that. This is another patient who you can see has aponeurotic ptosis and features of it with that really high eyelid crease, right? So that's quite long. She was actually very keen only to have her right eyelid lifted. And the reason that she only wanted to have her right eyelid lifted is because her left eyelid, her pupil was clear. So from her point of view, her vision was fine, and she wasn't looking for any cosmetic reason to intervene. She only cared about seeing better. And so once the eyelid is transecting the pupil, that's often when patients really notice it visually. But I had to tell her that she had to do both sides. And the reason that she had to do both sides, and you can see in her post-op, I did operate on both sides, is really because of Hering's law. And I try to explain this phenomenon to patients before they go into surgery, especially when they have ptosis on both sides. And if they feel that they just want to do one side, I think that they should do both. It's really important for me to counsel on this. So this is a patient. Let's see if I can play here. He's a very severe aponeurotic ptosis. You can see all the features. He's really using his frontalis muscle, and his eyebrows are sitting up very, very high just to clear his vision. And the reason I'm going to show this video is because I'll show the concept of Hering's law, which is that when we lift one eyelid, I want you to look over at the right eyelid here. As I lift the left eyelid, we'll see what happens to the right eyelid, and you can see immediately that it's coming down. So it has to do with the innervation, and I won't go into the details because we only have a little bit of time, but the concept is that we need to check this preoperatively, how much Hering's response we see. And another piece I'm showing in this video is actually how the brow comes down. So I don't know if you can see here, once I lift up, you can immediately see he doesn't feel he needs to use the brow anymore, and they come down and they relax. The reason that's important, and you can see me pinching the eyelid skin, is because a patient like her, when I counseled her, I advised that we should consider maybe a concurrent blepharoplasty, because I expect there to be several folds of skin after I lift the eyelids. And from her perspective, she looks at herself pre-op and she says, well, I have no extra skin. I'm not going to consider that. But even here, just by lifting the eyelid, already we're seeing some folds of skin. As months go on, the brows are going to drop, and they have nowhere to drop but down, and that means there's going to be even more folds of skin.
One of the questions from the webinar people is an aponeurotic ptosis always bilateral?
So technically, no. It often is an age-related aponeurotic ptosis. So for older people, it can be, but you can technically have aponeurotic ptosis related to contact lens wear. It really relates to weakening of the muscle, or it might be the side that that patient sleeps on, or they've had chronic dry eye on that side. So no, it is not always bilateral.
It's a thinning of the aponeurosis, the front part of the levator muscle.
That's correct. Thinning or stretching or weakening.
And do you ever have a latent ptosis on the other side where you're sure it's one side and then you lift it and the other still drops? Because the ones you've shown are quite extreme cases.
Exactly. That definitely happens. I would say that if I see more than a difference of 1.5 millimeters, I sometimes will operate on the other side, or I will tell the patient that I may make that decision intra-op if I already see a change happening intraoperatively. And if they trust me, and they often do, they say, okay, yeah, I trust that we can go ahead and do that side if you think that we need to do that side. But other times it doesn't uncover until much later, and then we will intervene. But I just wanted to point out, this is really exaggerated because I wanted to show how the eyebrows drop because of this thoughtfulness around blepharoplasty. This is another question. It has to do more so with, it's not Hering's law, but for young patients where I'm doing a ptosis repair, I don't know if you can notice, but he has quite a lot of inferior scleral show. And I'm in the habit now for young patients where I never adjust anything with the lower eyelid, because whenever I lift the upper eyelid, I find that that just balances itself out over time.
That's absolutely fascinating.
It
Goodness.
is. Yeah, I don't know the anatomy or the physiology of it, because it's not the yoke muscle of the levator, but it is a balancing act that is happening, and that's why it's so important to wait after surgery. If patients are sort of still noticing differences, I always wait at least 3 to 6 months, because our body does this amazing thing where it can often figure out how to balance things out just on its own. If this was a much older patient and they had a lot of lid laxity, that would be a different story. I would address that surgically up front. And then these are some quick fire questions. So these are patients that were referred for ptosis to work on the levator to lift the eyelid, but they were not really ptosis. What do you think is going on in this patient?
It's just the top lid.
Muscles getting weak and just the muscles getting weak and the lids feeling like they're drooping.
Right.
It's the skin issue, isn't it? It's more the skin that's coming over.
Right.
The top lid.
Inflammation?
Yeah, so good ideas. Really, this patient, it's just extra skin that's come down and it's overlapped on top of the eyelid, on top of the lashes, and the muscle itself is not weak. So just by removing the skin, yes.
Do you call this blepharochalasis or dermatochalasis?
I call this dermatochalasis. I refer blepharochalasis for patients who have episodes of swelling that we can't necessarily explain, and then subsequently they may develop sort of this extra skin, but on history they tend to describe these episodes of swelling around their eyes where it becomes very puffy as an initiator, but that's terminology that I use. And so this case is really just to show the mechanical heaviness of just skin. Her actual eyelid height is at a good height. It's clearing the pupils. I did not operate on the levator at all. All I did was operate on her skin. What about in this patient? Also referred to me as a ptosis, to do a ptosis repair. Yeah, so it's another example for sure where he does have extra eyelid skin, but a little bit different. So look at the brows here. If we draw an imaginary line from the top of this brow and go all the way across, we can see that this brow is sitting low.
Webinar people have said browtosis.
Perfect. So that's great. And that's a hard one to pick up on. If this is me just using a Q-tip to lift up his brow and to show that simply by lifting the brow, I'm able to clear the visual axis. Yes, he also has dermatochalasis, extra skin, but that's not really the reason that he's not seeing well on that side. And so this would be a patient I might consider a direct brow lift for. I often do that with men, and that's where I make an incision above the lateral brow, and I remove some skin and tissue, and then I suture. It heals really beautifully in men. It's often hidden very well by the brow. Our brows normally, if you feel on your face, you can feel the jutting forward of your orbital bone. For women, the brow should sit at or above, and for men, it's often a little bit below or just on the brow bone. But this patient, if you were to feel his brow bone and palpate it, you would find that his brow is actually sitting below the brow bone, and that's how you know there's a brow ptosis. Okay, we're near the end. I want to point out this patient with the brow ptosis. So this is a patient who has all three things going on. He has a droopy eyelid from a weak levator, so true ptosis. He has extra skin, dermatochalasis, but he also has brow ptosis. So all he wanted to operate on was the skin and to lift the muscle. And this is a result. It still looks like he has a lot of extra skin, but in reality, there wasn't actually that much extra skin I could work with to remove while still making sure he could adequately close his eye well. All of this sort of excess would be improved by lifting his brow and stretching his skin, and so restoring his brow essentially to the correct position. And so that's really important. I like showing these photos to patients to help explain why it might be important to lift the brow, because in their mind, they're just seeing skin. This is another pseudotosis, potentially. So this patient came in because she wanted to lift her right eyelid to make it look more like the left eyelid. And I'll give away the answer, but she actually has contralateral eyelid retraction. And it's somewhat subtle. What I use to kind of decide which eye is the abnormal eye is the eyelid should technically be intersecting. If we think of the cornea or the iris as a clock face, the eyelid should kind of sit around 10 to 2 or 11 to 1. That would be the normal position of the eyelid. And so you can see here, the eyelid is intersecting at the correct height on the right side, but the left eyelid is way above, and we're actually seeing some superior scleral show. And this is her after I did a retraction surgery. This is another patient, again, same idea, more severe. And this is a more involved retraction surgery in a patient who had a thyroid eye disease. I need to see stable measurements for quite a long time in these sorts of patients, and I want to make sure that they're non-smokers because smokers can have a second flare, and I don't want to intervene before they have another flare of their thyroid eye disease. Don't forget to flip the eyelid in patients who you're seeing have ptosis. They can have lymphoma, orbital lymphoma.
This is one of the most important things about ptosis. Always look underneath the eyelid.
Totally.
We've got about another 4 minutes. We have
Gotcha.
extended it. The same number of people are still there on the webinar and here,
there.
but we can't go on
I know.
too long.
Good. So flip the eyelid. This patient, okay, so don't look at the next slide if you're very squeamish. You can see that there's something here that's puffy, but you can close your eyes if you think you're grossed out easily. She has a ptosis, right? And this is an example of a mass. And so this is what I was removing from behind her orbit. It's quite a large cyst, and that was mechanically pushing down and creating that fullness there. This is just a shield. People always ask me, why is her eye blue? We have a blue shield at our clinic. And so that helped improve her ptosis. The last two slides, we're on the last two slides. Corneal exam is very important. I actually did not perform any sort of surgery on this patient. She came in because she noticed a really subtle ptosis, and her pupils were equal, full extraocular movements because we have to check all of those. All I did was start her on a dry eye regimen. And she actually did have a history of a recurrent corneal erosion that was more superior. And so by managing her just with our classic dry eye regimen, I was able to see an improvement in the ptosis. So please do a corneal exam and consider treating that before doing any sort of intervention. And this is the last question. Why is this patient seeing worse 2 weeks after surgery? She had a xanthelasma. She was bothered by the ptosis. We addressed the xanthelasma by doing a blepharoplasty, and I also lifted the eyelids. The eyelids, what do you think? So why would this patient dry eyes? Yeah, so that's the comment, and that's the correct comment. She has much worse dry eye. I always tell my patients before surgery that the risk of dry eye will be worse. I make sure I try to manage their dry eye in advance before they even consider surgery. But I mean, for her, this is a little bit high, maybe a half a millimeter lower would have been a slightly better position, but she may have still developed dry eye anyways. A lot of this comes down to reassurance about managing the dry eye. The other piece, in addition to dry eye, is that we know that when the eyelid transects the pupil, there can be astigmatism changes. And so after ptosis surgery, where the ptosis was more severe, you might actually get a refractive change and they need an updated pair of glasses. This is what we covered: life-threatening causes of ptosis, a standardized approach to ptosis, and then ptosis versus pseudoptosis. And that's it. Thank you so much for staying on.
I just want to thank you, Lisa, from everybody here in the audience and at home for an absolutely spectacular lecture on ptosis.
Perfect.
We've all learnt a lot, both optometrists, GPs, and oculoplastic surgeons and ophthalmologists. A big thank you.
Thanks, Jane. Thanks for everyone attending. Sorry to go over. Okay.